It's a real pleasure to introduce Ayla Harris. For those of you, I don't know that I recognize any of the faces from yesterday's discussion, but we had a whirlwind review of what I think is one of the, what I would want to be when I grew up. What Ayla's accomplished in her site in Managua, Nicaragua, with her commitment to the people, her commitment to the science, is really, really remarkable story to listen to. And so she is a professor at California Berkeley School of Public Health. You can see all of her titles up here. She's speaking specifically to you guys today from a very different perspective, I think. I don't want to speak for you than we did yesterday, where we covered everything from the complex epidemiology of multiple viral infections to the molecular biology of those infections and how they interplay, and the tools allow us to actually learn about the epidemiology. To today, speaking really about her nonprofit efforts there, which is the Sustainable Sciences Institute, which, again, I think shows her holistic approach to the other side. But that's my introduction. I apologize, I've actually got to leave, so I can't partake in the discussion. I'm jealous of y'all's opportunity. And I'll come back and meet you and work on that.
Okay, great.
Okay.
Thank you very much, Chris. So this is utterly retarded looking, but is this okay? Because otherwise I can't carry all the different objects I'm supposed to be using today. So thank you all for coming. It's really nice to see you, and thank you for see the people from UNC. Actually, I did talk about something else yesterday. So, and the problem is I kind of assumed that people might have been at the talk yesterday, so I was just going to refer to everything that I told yesterday, and maybe that won't work, but we'll just have to see how it goes. So, what I'd like to do today is to tell you about the work that we do and have done for the past, I don't even want to admit this, like practically 25 years, following this vision that I had a long time ago, which was to bring tools to people around the world to deal with their own problems. And that was a very simple idea, and it's still a simple idea, and but it's still somehow, I still feel actually that it's not really the way global health is, even though when I started it, global health, the term didn't exist. I used to call it international science instead of international health, and then it just was kind of way before the time. And then now global health has become all the rage. But I actually still think that we can learn from listening to people in other countries and addressing their problems. And I think that it's really important to bring our humility to the international scene, because this is not about us, it's about them, and it's about what we can do as partners. And I think that that's just a really important point to keep in mind in all of this global health as it becomes all the more trendy. But anyways, enough proselytizing here. We'll get to it. So what I wanted to talk about was the work we've done, not as much in the university, but through this nonprofit organization called Sustainable Sciences, and the vision that entails, and and the public health impact that that's had. And then I'll talk a little bit about where that's led us as an example in Nicaragua. And then I'm going to just end. Actually, what I'm going to talk about is really the biomedical aspect first, and then a whole story about the informatics, so e-health, m-health, and a whole kind of story which is completely out of my realm, but is all about, you give people ideas and then you support, what they do with them, and so it's really the whole story of this is really, it's that classic kind of, give the fishing rod instead of the fish, give the tools and let them run with it type of thing. And so this is just the story of kind of me following along all of our wonderful colleagues in different countries. And then at the end, I'm going to tell you a little bit about the Center for Global Public Health at Berkeley, just in case any of you are ever thinking of going out to the West Coast. And I'm the director of that center, and I just wanted to let you know a little bit of kind of what's going on that side, because this is the Global Health Center here at Duke. So now I think I don't really have to convince people, but in the old days, the idea was like, why are you doing research, but really, this was from the WHO Global Forum for Health Research, and this was, from probably in the 90s, a statement about how strengthening research capacity in developing countries is one of the most effective and sustainable ways of advancing health and development. So, not just like coming up with gadgets here and then delivering them, right? It's about actually bringing the tools and the methodology so that people can just apply it to whatever their own problems are. And then that methodology and that knowledge stays forever, no matter what the problems are, right? As opposed to coming and identifying something and you coming with a solution. Here you're bringing the tools for people to sustainably come up with their own solutions. And this 1090 gap refers to the fact that essentially there's 90% of the world's population suffer from diseases that only 10%, it's really more like 5% of funding is directed to, and vice versa, so that the 95% of the funding in health actually and science goes to diseases that affect 5% of the world's population. And a lot of that money, actually, even the money that's directed to those problems of developing world, actually go to developed countries to do the research. So it's even worse. So the question was, what can we do to actually make a difference? And so I don't need to tell you this, because I'm sure many of you are either from or have experience in developing countries, but there's this litany of issues that you're up against: limited material, financial resources, poor infrastructure, lack of scientific careers and higher degrees. In Nicaragua, where I work, everyone's like, oh, well, you could get a postdoc, and you get a postdoctoral fellow. Like, post what? I mean, there's no doctoral program in Central America. Like, there's no doctoral, it's just, there's maybe some master's programs, but, it's like a completely different ball of wax, I mean, there's a number of countries that I wouldn't even call developing, like Brazil and, Thailand and South Africa and, India, etc., China, where, it's very advanced. And then there's like a whole lot of countries that just don't come close. And so, there's this kind of the digital divide. I call it the scientific divide, because, you can keep getting people who already have resources, more resources and more training, but then what about all these people over here? How do you move this whole story along? And so that's kind of what I wanted to do, is to address the smallest, the poorest nations, where I felt that we could actually make a difference and just slog it out together. And so, where there really is no scientific tradition, and we've done, I'm really excited now. There's some structural changes that were going on in Nicaragua now that we're really pushing to create the first National Institutes of Health, which will actually take scientific investigation to a whole nother level. And we're just in some talks about that now, which is really exciting. Absence of a local scientific community or critical mass, a kind of technical basis for training as opposed to a more like scientific visionary. A lot of people are trained very well to do experiments and to move 5 microliters from here to there, but then you say, okay, let's write a proposal, let's do the budgets, and so that's the kind of training that we try to give. And of course, cultural and political issues exacerbated by scarcity of resources. And so what we came up with was this idea. Initially, this started in 1988 when I first went to Nicaragua, and was really just struck by the tremendous need on the one hand, and then the tremendous desire and capacity, of people in Nicaragua, and then also people everywhere who had read about our work and wanted to help to get involved, and that's what's tapping this huge interest in global health at the student level now, for instance. And so I want to tell you a little bit about programs. So we started this as kind of a virtual organization for 10 years, and then in 1997, I was awarded this MacArthur Genius Award thing, and then we were able to use that to found an actual organization, so a 501c3 nonprofit organization that was then able to kind of take it to the next level, so that it wasn't just me going with my friends and colleagues to all these countries, but we're able to hire a scientific director, and then et cetera. Well, I went back and created a program at Berkeley on the more scientific research side. So I'm going to tell you about some of the impact we've had in training, give some examples in public health, focusing on dengue, influenza, and then this whole story about ICTs, and hopefully at the end get to this idea now. Remind me about my scaling out idea at the end. So the programs for training that we do, it's very simple. And the first thing, unfortunately, I really feel that a lot of what goes on in the global health arena is still this kind of top-down approach. Gates and a bunch of, people up here thinking, what are the problems out there? We have an idea, we'll write a grant, and there's, of course, everything is done in collaboration, right? So, you have wonderful partners, and I'm not saying that they're not brought in, but a lot of times the ideas is actually coming from here, and as opposed to listening, going and being there and saying, what are your problems? Okay, let's think about how to address that, starting from starting from there, starting from the south, as opposed to, coming in with the idea from the north. And so what we try and do is to strengthen local scientific capacity and to really push. There's like an advocacy role for this kind of keep the little call out there, letting people know that there are inequities in health research and that we need to facilitate this knowledge exchange and really look at the smaller countries as well. We're conveners, we build networks and partnerships. We essentially, as you'll see, we kind of start with workshops and then we go on to work with countries that are interested in the long term, and then they become centers of excellence, and then they become centers for the rest of their region, and then so it kind of goes on, and we use extremely much this concept of like the multiplier effect. It's all south-south. In our workshops, there's maybe one instructor from the north who's not even. Marilena Peñaranda is our scientific director, but she's actually from Costa Rica. So but there's really, we then bring everybody else are essentially people who had taken or had partnered with us from other countries in the past and who have now become instructors in their own right. And so I'm looking at people who collaborated with us over the years, which is really lovely. And so what essentially we have several programs. One is a set of training workshops, and so. Sometimes, as I mentioned, there's a kind of an input from the north. A lot of those tend to be our manuscript writing workshops or our grant writing workshops. The south is really, all the techniques that are out there, and you'll see a number of different areas that we're in where it's, where essentially it's just people from one country teaching other people in the region. And then with the material aid, we have this loads of stuff which is donated from biotech companies or universities, but we don't just say, here, go find something. It's more like someone says, we really need it. We have this, connections through the web and through our emails and contacts where someone says, we really need a thermocycler, or do you know if there's a clinical centrifuge, or do you know, so then we match specifically, what people need. And actually the nice is that we're kind of tired of this, to be honest. It's like back-breaking labor in a very literal sense, but there's some wonderful, we worked with a group at Harvard Medical School, some students years ago started their own group, and actually now they're called, oh my God, Seeds. I'll tell you at the end of the Seeds something. It's a very lovely nonprofit. They have nonprofit status. They've got personnel, and they've just completely created their own story. So now we just go, guys, talk to them. So it's really nice to see how that kind of, that multiplier effect happened not only, in the developing country work, but actually right here in the United States. And then we try, when we can get any funds, we try and give small grants, that just very small grants, but they really actually goes a long way for people to actually apply the techniques that they learn to their own projects, and then to get enough preliminary data so that they can write their own grants and be successful as applicants. And then this big networking and consulting, and again, like I said, a lot of this then moves into centers of excellence at either ministries of health or universities. And so this started with the concept, and I'm sorry, should I dim the lights here? I don't want to turn is that better or not really?
Yeah, that's better.
It's better? Okay. Okay, don't go to sleep now. All right. So the idea was, actually my PhD is in molecular and cell biology, so I was like, pipettes. I understand pipettes, and so that was kind of where it started with, and I was like, okay, other people need to understand pipettes. So we kind of started with the idea of the laboratory, and of course, diagnosing diseases, etc. But I soon realized that it's much more powerful when you connect it with the epidemiology of the country, right? Because it's amazing when you go. A lot of places are just processing samples and then throwing them out, and they just will report into the Ministry of Health there were this many cases, y punto. That's it. And you're like, oh my God, this is an outbreak, a cluster of TB. You could type these, these strains, and you can, and they're like, oh, and yeah, and then, what about, if you can stratify by knowledge of, say, what the infectious organism is or what the clonal population is, then you can direct your intervention much more specifically than if you're just saying, oh, well, there's some diarrhea in the community. But if you know what the organism is, or if you know that, actually this is, say, community-acquired, versus a hospital nosocomial infection, you can tell that by typing, then, of course, your intervention would be much different. So the idea was to say, you've got this information here, now couple it, to the epidemiology. And that, of course, required teaching epidemiology. And this was actually a course in Bolivia where we had recruited Dr. Lee Riley, who is also at Berkeley, to give a lecture and to come down and teach this whole, Epi-Info 6 was the old version, but how to actually use statistical software and epi software. But then we realized that, that's fine and good, but there ain't no money, and so, what do? We write grants. Well, what do people do in other countries? They don't have how to write grants. A, they don't know, and B, where are they going to send it? Very few countries, certainly in Nicaragua, there's no money for health research. You know, and in Guatemala, sometimes there is, so you got to like jump on that, you know, while it's there. But, you know, a lot of countries don't have that. So where do you go? Well, you try to go to national and places like CONICYT or National Institutes of Health locally, or to PAHO or to the TDR, or to do partner grants. But the idea is that, you know, people need skills to be able to do that. And then, you know, that was what we came up with. But then it's like when we started doing this, all of a sudden, all these other ideas started coming from all of the people we worked with. And again, that question of like listening, and they were like, we want to learn how to write manuscripts. We're like, okay, fine. And then of course, I'm like, of course, like these people are doing all this work, and where is it? Physically on a little piece of paper stuck in this corner with a bunch of dust on it, and nobody in the country can even access their own data, let alone in the international community. And so the whole question was, you got to get your results out there, you know, not to mention the fact that in a grant proposal, your metric is the number of publications, right? So it's like there's a dual necessity, A, to get results out there so that they're useful for your country and useful for the world, but the other is also to increase your chances of being able to get funded. And so, so we started this whole series of manuscript writing workshops, which became incredibly popular. I think that we give way more manuscript writing workshops than like everything else combined, and it was completely driven, you know, by the people we work with. Another thing that they wanted was bioethics. You know, here there's a whole IRBs and it's a, you know, and all this, and you know, here you learn, okay, this is how you write it and your consent form and everything. But there's a lot of really tricky questions. Like, you know, when you have a study in a community, like what's your commitment to the community? Of course you feel a deep commitment to the community, but when that comes down to like, so how long are you going to run that clinic, you know? Or what if the people coming are not part of your study? Or what if they need, you know, a higher level of medical intervention? Is your study going to cover that? Or what happens 20 years after that vaccine trial? I mean, you know, there's some really, you know, thorny questions that, you know, from the outside you'd be like, oh, of course. And then you look at your budget for the grant and you're like, you know, so there's a lot of real tricky questions about how you do research in a sustainable way, and what you're, you know, how you maintain a commitment with the community that's also consistent with, you know, with the restrictions of like, say, NIH grant funding or something like that. But there's a lot of issues that people wanted to address, and so we worked with Richard Cash and colleagues at Harvard to put a series of workshops together on bioethics. Then bioinformatics comes up, and, you know, so we have a whole, this I'm going to tell you at the end, but, you know, we're doing all the sequencing. I'm not going to talk about this today, but we have some very nice projects on dengue, on sequencing dengue and influenza out of our studies, and I just thought, this is ridiculous. Like, we're killing ourselves with the study. We're like isolating all these viruses. They're being sent off to like the Broad or, you know, the J. Craig Venter Institute, and then someone else is doing the analysis. That is so not right. So we organized a phylogenetics workshop in Nicaragua, you know, so we had, we brought people from the Broad and from the University of Washington and from a bunch of places, and went through, you know, their own HIV sequences and their own dengue sequences, and I was even there too. I don't know what the cluster on this and such and the other, but, you know, we all slogged through it and, you know, and learned, you know, how it is, what is this magic that happens once you get a sequence, you know. And so we have people from the whole Central American region, and, you know, and some of them are going on with that work, actually, you know, and I think that that's really important, you know, even if it's not going to lead to like 25 papers, you have like a moral commitment to, like, you know, bring the science out, you know, all the way to its conclusion, because otherwise it's just, you know, it's not fair. This IT and health I'm going to talk about in a moment, and then program evaluation. You know, this is another really important point. A lot of things just kind of come in and you just do an intervention, but then there's no evaluation of that, you know, so then you have the funders come back and say, so what happened after that? And there people are like, I don't know. So then the funders come in and do their own program evaluation. But when I was meeting with the Minister of Health, you know, a couple years ago, he was like, you know, we want to do our own. Like, we want to know the methodology for how to, like, institute our own impact evaluation, our own program evaluation before the World Bank comes and says that they want to do it, you know. So anyway, so this is just like, all of a sudden, none of this would have occurred to us other than that we were there working and trying to respond to the needs. So I'm going to go trotting along here. But the idea here was that when I first came to Berkeley, I thought this is so cool because there was this Office of Technology Transfer, and I'm like, this is so amazing. Like, here I had this idea, and the institution already is on top of this. But of course, my idea, they're talking about taking something to the bench to manufacturing, you know, which is really important on its own right. However, it wasn't what I thought, which was taking it out to the bench into the field, you know, and actually making it useful. And so that was what I wanted to have done. And there's some really important aspects, you know, to do it in country, because, you know, it's in real time, so you can actually respond to an epidemic, and you get local insight. You know, we were able to diagnose a completely new form of the leishmaniasis, a parasitic disease, because it wasn't what they thought it was, and we could tell that using some molecular techniques that we'd implemented in Nicaragua. And then we were able to use the local insight of the doctors who said, actually, no, maybe this is it, and then we were able to link the molecular biology with the doctors, the physician's insight at that moment and come up with this essentially diagnosis of a cutaneous leishmaniasis disease that actually had not been seen before in Nicaragua. And so we're talking about these constraints. So this is from a long time ago, but this is from the work that we were doing some courses in Bolivia, and there was this lab at the Universidad Mayor de San Andrés, which is in La Paz. And not everyone can buy fancy pharmacy, whatever, QIAcube, RNA extractors and such like this. And so what do? They just local invention. So this is what we call the blender-fuge, and this is essentially it's a blender with a little aluminum plate and then these widgets that go on the faucets, and they have a little centrifuge, and this is a record player that's been translated into a back and forth motion, and it's now a shaker, and so this was like brilliant. And I was like, but we went there. I was there in 1987, 1988, and like they were so embarrassed that they wouldn't show this to me, until the second time I was there. They were like, okay, and I was like, embarrassed, man. This is so cool. But it's like that whole mentality. It's got to be clean and white and got little lights going on and off, and it's like, no, this is cool. And so then I wrote this book a bunch of years ago on this whole experience, and I made this appendix, and like Appendix A, this was like Oxford University Press, was like all of this stuff that they had done, and I thought, oh, this is the coolest thing, but oh man, you're like liable when you publish something, right? So I'm like, okay, you got to be really careful that and I'm not going to like electrocute somebody if they do this, So anyway, so that was fun, and after that they got so really proud of it. So now there's they made a course at the university, about how to make your own lab equipment, and everybody who rotates in the lab has to come up with their own little gadget. It was cool. This little clothespin that actually you can tell whether the current's running in your gel electrophoresis because a little light goes on, and oh my God, all this stuff that is just super. And then of course alternative techniques. We certainly started. In fact, we started doing PCR in Nicaragua in 1989. When it was actually being done by manual cycling here too, and so this is how we got the first data on diagnosis of leishmaniasis in Nicaragua, a country that had never seen DNA before, and we were able to actually implement a national program for diagnosis based on PCR because it was more sensitive and it just fit the niche. It was really cool. But of course, we did it by manual cycling, and then got data, and then of course we were able to buy a thermocycler because there's only so many times that you can do 30 cycles like this, But actually, part of the thing was actually going to the countries and working with people and doing it there, because this was a funny story. So you know that there's 3 cycles. I'm assuming everyone knows what PCR is, right? And so you've got your denaturation, and then your annealing, and then your extension. Okay, so your denaturation, annealing, extension, and you just so the idea, of course, is that instead of putting the tubes into the thermocycler and having the temperature go around the tubes, you actually can make the tubes go around the temperatures, right? That's the concept. And it's really important. For a long time, even when people had thermocyclers, we kept doing this because physically, then you understand the biochemical and the biophysical processes. And so it's all magic, right? A little tube, but you can't see anything, looks like water, and then suddenly, poof, something comes out the other end. And, we always have this knowledge-based approach. Why are you using 5 millimolar magnesium? And what does magnesium do? What does the glass do? The glass milk. I mean, this is just like powder, glass powder, and it can bind DNA of the opposite charge, and that's how it pulls it out. What are you doing in these different temperatures so that people really understand? Because how can you troubleshoot if it's just A and B and then it turns blue, right? I mean, it's got to be a knowledge base because people have to be able to have the tools to understand what they're doing. Anyways, but the funny thing is that, so this was in actually Quito. And so we got there a couple days before to work through all the techniques, and so we couldn't get this stupid water bath wasn't working, and it was 89, 88 degrees, 89 degrees, and I was like, oh, I can't believe, get another water bath, and it didn't work, and then we're like, wow. And of course, why? Well, Quito's 9,000 feet up, and water boils at 89 degrees, okay? 80, so we're like, oh crap, totally didn't think about that. Berkeley didn't occur to me sitting in Berkeley, and so this is why you get your butt out, And so what we did is, this was clever, so we finally put a layer of oil on the top because you can approximate a closed system. And that way we could drive it up to 92 degrees, which was fine for denaturation, etc. But of course, naturally, what do you write with? You write with indelible markers. Indelible for what? Water, not oil, right? So of course then all of those markings go off the tubes. But they were like in order, so we were fine. But then it got worse when you go to La Paz, which is at 12,000 feet, and then the water boils at 80 degrees, so we're really screwed. Anyway, so, but you got to get out there, right? It's all about kind of making it work where you are. And so, here, saliva samples for testing. We have a whole project in the community, big. We just collected 5,000 saliva samples for a community-based project on dengue, and we can look for antibodies to dengue virus in kids' saliva. Instead of taking the blood, you can actually detect them in saliva. They spit. This is great. These are those little cups for spices in Chinese restaurants, and then you can place them perfectly into egg cartons. It's the right size, So then you can. So that works great for like being on the field. Or if you need the blood, then you try and avoid the cold chain. So blood on filter paper, and you can even get RNA out of this stuff now. It's really amazing. Anyway, so we've done a lot of workshops and trained tons of scientists from different countries and implemented the techniques, and a lot of articles have been published. But really importantly is the grant proposals, but also just the ongoing scientific collaborations and the fact that everywhere we've gone, they've actually implemented whatever technique it is, So, whether, and then it moves, right? So first we say, okay, you need something for dengue, fine, dengue, and I come back and they're doing PCR for like chlamydia and gonorrhea and, TB, and because they can, once they got the idea, they can, we've got ISO 9000 certified labs in Ecuador and everything. I don't know the first thing about that, right? But they just got it and took it, and it's really cool stories. So I'm going to be here for 2,000 years. You got like a couple, 3 hours here. Anyways, so just to give you some idea, so one of the applications of this was so dengue, which I work on now, but it's a major public health problem, and it's got this nasty twist, that it's got this shock syndrome that people can die in 24 to 48 hours, and we don't know who is at risk out of the 100 million infections that are going on annually. The other problem is that there's 4 flavors, and so there's dengue 1, 2, 3, and 4, and having one infection makes it a lot worse. If you get a second infection, you're at higher risk for severe disease. So it's important to diagnose the disease, but it's also important to identify what serotype it is. And also, this is an acute onset febrile illness, so it looks like there's a ton of stuff that it can be the differential diagnosis, influenza, rickettsia, all kinds of other things. And so, but the problem was that prior to applying molecular techniques, you either had to isolate the virus, which would take like 1 or 2 weeks, or you had to do serology, which will not tell you what the serotype is, but also takes about 5 days for antibodies to come up. So if you want to do like an immediate intervention and you want to know there's dengue, send in, because it's transmitted by mosquitoes, and so you want to get in there and kill the mosquitoes and do some emergency actions, and you're waiting around la 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 la, and then 2 weeks later you're like, oh, that was dengue, oops, and by that time it's like the epidemic has totally spread. And so what was really great was this PCR where you could just lump everything together in a single reaction, and what you can do, it's an RNA virus, so in one tube you can do an RNA extraction, reverse transcribe it, and then come in with primers, like one that's, this was developed initially by Lanciati at the CDC, but one conserved primer at the 5' end, and 4 primers to each individual serotype at the 3' end. They give you different size bands, and then within 24 hours you can know what it is, what's out there, whether it's dengue, B, what the serotype is, and actually, we've actually shown that it's been able to be useful. So, for instance, this was in Lima, Peru, we did a workshop, and this was with the Ministry of Health. So, ironically, there's actually NAMRID, the Navy has this very long-standing collaboration, well, I shouldn't say collaboration, they have a long-standing scientific interest and a big program on dengue for, I don't know, decades, and yet the Ministry of Health was unable to do its own diagnosis of dengue. And I kept saying, well, we're not going to get involved, just go talk to them, but there just wasn't the incentives, I guess, to do that kind of training. So we sent some Nicaraguans over, they did it, and then literally 2 days after they left, at around 5 o'clock in the afternoon, they get this sample in, and by 1 o'clock in the morning, they have it, it's dengue, it's the first outbreak of dengue in Lima. And they were able to do it in the Ministry of Health immediately and be able to actually do something about it. That was one thing. The other was in Paraguay, where kind of a similar story happened. This was where there was a dengue 1 epidemic this was now a long time ago in 2000, but there was no dengue in Paraguay, so there was not one single diagnostic tool available in the country. And so they scrambled and figured out eventually that it was dengue, but they didn't have any of the techniques there, and they were like, CDC, WHO, and everyone's like, by the way, where is that? No, not really. And they're like, Eva, I'm like, okay, and so like the smaller is beautiful. And so, we went down, but we insisted that they do a collaboration with the university, which was going to do the molecular part, with the Ministry of Health, which was doing the surveillance and the serology. We always insist that they try and do intra-country collaborations, inter-institution. Anyway, the bottom line is that we set this up, and then right after that, there's this huge outbreak in Brazil, which is over here, of dengue too. And so we started doing this active surveillance, and they actually picked up dengue in an active way, this doesn't work, right around the bus stations coming in from Brazil. And they were actually able to send in teams, and okay, so there was there was no epidemic, but I mean, was it because we prevented it? I mean, that's the issue with prevention. Like, you never can really say. But the truth is, dengue was coming in and it never spread, so that's good. And then, like, the next year, there was a dengue 3 outbreak in Brazil, and they were also able to contain this, and it never spread. So, it's like negative data, but it's, good negative data. And so that was one thing. Another was what really started this all off in Nicaragua, where there was essentially this was, again, we had just set up dengue in Nicaragua in 1995, in July, and then in October there was this big outbreak up in the north, and they were like, it's dengue, and then they sent down the samples, and within 24 hours it wasn't dengue. So I'm getting these calls, and they're like, Eva, we ran the gel and it's blank, and I'm like, well, what are your controls? And they're like, well, yeah, they're positive, all 4 are coming up, and this and that, and what are your negative? It's your contamination controls. What about this? And they're like, no, and I'm like, guess what? It ain't dengue. Oh, and so that was like the first concept that it wasn't dengue, and then it came down to serology was negative, there was no mosquitoes, and it turned out to be leptospirosis. Now, we didn't detect the leptospirosis. That took international teams from the CDC and from the IPK in Cuba, but the point was that was like the red flag, and that actually put lepto on the map, and CDC has like a branch devoted to it, and so it's really but the idea is, again, you got out of that stuff in country. I could go on forever, but the same thing, we're working on influenza, so we thought, why not also set up other respiratory virus testing? And so then they had that in the Ministry of Health, huge outbreak of something, a lot of kids, this is in August, it was horrible. I was in the pediatric hospital, and there was like infants dying left and right, and they didn't know what it was, so they put in a call to the CDC. By the time the CDC came, they had the etiologic agent, they had the interventions going, they were able to resolve this on their own. And it's just that kind of a story. So what we start with is like these successful, what we consider workshops that just have really logical stuff, every participatory, you listen, you address the problems of the people, you work together, and then you go beyond the workshops to projects, so you support so that people can actually use what they learned in their own lives. And then beyond the projects, ideally you publish this, but really it's implementing this, to make a difference in the country. And so that I was trying to give you some ideas or examples of how that's happened. And what I'm not going to talk about, a little bit, this is just dengue, and I talked a little bit about the problem. It's really this uncontrolled spread, mostly uncontrolled in 3 different ways. This huge increase in numbers over time, a big increase in geographic dissemination, and also in the co-circulation of different serotypes, which puts you at risk for more severe disease. And I'm not going to, this is what I spent a lot of time talking about yesterday, but it's just been this it's gotten bigger and bigger and bigger, and so, we first just started adapting this application into different countries, and then developing, more types of techniques, and then establishing these lab-based surveillance systems that work with the laboratory sector and the clinical sector and the epidemiological sector, which seems really obvious, and it's really hard because a lot of times, unfortunately, those sectors work independently. And so the key is to link them together. And so we made a model that we could then start exporting to other countries. And then the Nicaraguan Ministry of Health started acting as instructors like all over the region, and modeling stuff on it. And then we had a lot of studies looking at risk factors for severe disease, now a 7-year cohort study on dengue, which is now a foundation for influenza work. Community-based studies, we now have a random control trial underway for an evidence-based approach for people to control the mosquitoes on their own. And so by now we're pulling in over $1 million of funding per year in Nicaragua, which really just grew out of this whole effort. And it's, but we now have, used to come through me and then this and such, but now like the PIs in Nicaragua, they've got 8 grants from NIH and from other places, that are essentially, he's a PI and I'm a co-I. And so it's, some are subcontracts through Berkeley, some are directly there, but it's like this is what, can happen over time. And so I'm not going to talk about this, but we have these 2 studies that are long-ranging. One is this hospital-based study that we've had going since 1998 on dengue, Another is a cohort study with following 4,000 children prospectively. Now 7 years, and we're going to continue another 3 to 5 years. And but the cool thing was that this is this cohort study where we're following children, and we take a yearly blood sample so that we can look at the dengue antibodies, and then we follow them during the year for all of their medical events. Okay, and so we thought, oh, this won't be so bad. 200 cases of dengue, not a problem. Yeah, well, 200 cases of dengue and 80,000 consults. So we're like, something else is going on. So I had this wonderful graduate student who's now postdoc, and so she was like, had just taken her qualifying exam on influenza, as it turned out, just randomly picked it out of a hat at Berkeley, and then she moved down to Nicaragua to work on the dengue project for 7 months, and she still was like, influenza. And so we looked back, and there was like no data about influenza in the tropics, and no evidence of seasonality, and no nothing. But then we looked at our own data. We're like, well, there's 80,000 consults. Wonder if some of that's influenza. And we ended up with this like prospective study now. 4 years we've actually been doing respiratory swabs and laboratory confirmed influenza. And I see seasonality here, and so this is every June you get this incredible peak of influenza. And the burden of influenza is exactly what it is in the United States. So there's this myth that it's not a problem in the tropics and it's no seasonality, and and in fact there is. So this has led to a whole bunch of questions about the disease burden and about vaccination and about the phylogenetics and all this. And then other respiratory viruses. If we've got the swabs, we might as well test for others. And nothing's known about what's circulating. There's like zero data from Central America on pretty much everything. So there's a lot of ways to go. And then this was really useful because we've been working really closely with the Ministry of Health all this time. And so what happened was, when, of course, in April, we all know, April 2009, Mexico, H1N1 pandemic strain. By May, we already had set them up, we'd got some CDC protocols and from the WHO, but we went down and actually made that happen so that they were totally prepared and were able to do RT-PCR for H1N1 pandemic strain. And even though they were surveilling the country, the first case was detected actually in our cohort. Just because of that level of surveillance that we had going. And then, so that's been really interesting. And now we've got this fascinating hypothesis that I presented yesterday, that we had this very strange dengue epidemic in 2009 as well. And my hypothesis is that there's an interaction between the H1N1 epidemic and the dengue epidemic through an immunomodulation, which was what we're trying to prove at the level of both the human serology as well as a mouse model that we're now starting to build to test that mechanistically. And I'm excited because yesterday I said that we did not have hemagglutinating antigen, but I was on the phone all night with Nicaragua, and we have our first virus out of eggs that actually is hemagglutinating, and we need to do this hemagglutination inhibition to be able to prove that that's what's going on in the sera from these kids, which we can go backwards in time to the samples that we've already collected. So this is like a really nice story, I think. So, and we just got funded for flu for a 5-year cohort study, doing some household transmission in a birth cohort, full-length sequencing and spatiotemporal modeling that incorporates genetic distance as well. And then looking at negative samples, we actually collaborated with Joe DeRisi through this. We actually have there's a paper that just came out on a new enterovirus, HEV109, which was discovered in the negative samples. And so there's some interesting stuff about that, and then modeling transmission and looking at risk factors. So that's kind of, so the idea is, that there's technical issues that we can overcome, and there's a whole bunch of short terms, like what makes something successful in the short term, and then there's like what makes it successful in the long term, and a lot of it is sticking in there, and also looping yourself out as much as possible. Now, granted, yes, I still work in Nicaragua because I'm in love with the country and with my friends and with bailando toda la noche and all this, but it's the idea is that you're there, you're not there on like this like tourist trip to like see like ooh how the other world lives. It's really about taking it seriously and being there. And if you can't go back, it's fine, but you're there as a presence. If you said you were going to do something, if you said you were going to investigate a technique for them, then you do that. Or you pass that along to a colleague or something, but you don't make empty promises, and you're there. You're there for the long term, because we have to make this interest in global health something which is respectful and respected. It's a really big commitment. This is what my biggest worry about all this stuff with the trendiness of global health is that, it's going to be trendy, and this is not trendy, right? The world has a lot of problems, and we got to solve them in the long term. Not just as long as you want to, be in a club or do this or that, or So I think that it's really important to take it seriously. And now I'm going to just rip through this part about the informatics, because, so this is funny, I'm all about biology, right? I don't know crap about computers and all this. I mean, I rely on it, but I don't know how it works or whatever. So when we got this big grant, this practically $1 million grant per year to do this big cohort study, the first thing they said, well, what about, you thought about barcodes? I was like, what? No. And of course, ironically, people had said before, have you thought about PCR? And I'm like, of course PCR. And they're like, but there's no water or electricity. I'm like, not a problem. And then now they're like, what about barcodes? I'm like, huh? And I was like offended, right? Why would you do, this is not their biggest problem. But then, after I don't know, a couple months of being in the study where we're trying to track 4,000 children in a place that has no addresses. In Nicaragua, literally, you say 20 varas al lago, so it's like it's not even a block, it's like some random measure of distance, al lago, which turns out to be, south, and then, or up, which is east, and, it's from the, in Cine, and you're like, what Cine? Well, there was a movie theater a couple years ago, but from there, and it's not a problem, once you know, seriously, el arbolito. I'm like, what arbolito? So there's an arbolito, a little tree, before the 1972 earthquake. I'm like, thank you. But, people know it, right? It's like an abuelito. And so as soon as you know it, you're fine. But, but if you got to go back and different sets of nurses are going out there, it's useful to have some way of tracking. And then how do you find these children and whatnot? So my Nicaraguan team then came to me and said, we had one informatics director and one other person. And now we have over 15 people in the informatics department. And so they were like, we'd like to use, barcodes and fingerprints and PDAs and the GIS, and we're like, okay, we can buy some of these things and see how they work. And they created this amazing system, which now a lot of people are doing, but in 2004, putting all of those together at once was actually novel. And so, there's all this, it's just incredibly useful. You come in, you can just have all the information, is it hemolyzed, is it not, where is it? We have hundreds of thousands of samples, and they can find it immediately, and 25 freezers, and meanwhile I had this postdoc who left the lab and I never found her plasmids. We had to recreate everything from scratch. How annoying is that? Anyway, so we use it on our medical charts, right? Because we've got some kids consented for dengue and some of the kids are consented for influenza and some are consented for DNA. But you got to be really careful that you're not taking the wrong sample from the wrong person, and so you can do this using barcodes as well. GLP, you go around and just measure. You can actually attach a scanner to a PDA, and then you can take the temperature of all of your freezers and this and such. And then how to find the children. So I don't know how it is in the countries that you are from or work in, but this was how you found kids. And so it was when you come to admissions. And so for a while it was the kid's name, but then Nicaragua have several names. So it's like Jose Antonio de Vallecillo de Gato, and so they're like, what? And so they couldn't figure out, how to find you'd think it would work, but it didn't. So then they changed it to birth date. So that's really clever because you got the mother and they can probably get the week right, and then you've got the grandmother and they can get the month right, and then you've got the father who may or may not come in, who can maybe get the year right, And so it's seriously, so these kids are having 4 medical charts, and we're like, no. No, not for this kind of study, right? We're going to have people coming down and auditing this from vaccine companies. No. So it took us 6 months, but we were able to actually get a numerical code. And then, and we can link that to either the fingerprint scan or their barcode. And then, boom, they come in, pick it up, zip, and now it's just there you go. There's all our kids, and you can actually find it. And so, of course, being the scientist, I'm like, okay, this is informatics, but we can still apply scientific methods. So how fast is this? I want to know what these techniques are doing. So we measured it, and so essentially, if you're locating a medical chart, it takes 5.5 seconds on average. We did and it was 473, records, and then if it takes a lot longer if you're using a standard method. And we did this for all of the techniques. And interestingly, for instance, entering with a PDA versus digitizing, incredibly, the PDA was not any more accurate because they're freaking good at putting in. This is what they do for a living, right? They're good at digitizing. But so it wasn't. Surprisingly, it wasn't the accuracy that was better. It's the access to the information, and it's the rapidity of getting that information, and it's having backups sent in from the field, while you're collecting that information. So it was what are these techniques doing for us, And so we published that and whatnot. GIS is really useful for essentially the logistical planning of where you're going to go out to these children. And then it started expanding. So then they're like, oh, this is cool. Let's make this work in the lab. So they made all these incredible systems for every single technique. you just come in, like the PCR, it's like, you know what you're doing, and then you know like what the reagents were and what lot they were, and then what lot that was, so that if you have a problem, you can work it backwards. You know, like all the ELISAs, you just go and it makes the protocol, and then it calculates the standard curve for you, and you know, all this stuff. I mean, like nothing doing with what happens in my lab at Berkeley. You know, it's unbelievable. So all these amazing outcomes, you know, improvement in quality control and GCP, GLP, and streamlining, increased efficiency, real-time analysis, and really importantly, building local capacity, because essentially of the 10 people that we hire to do data entry, they're all actually software developers now, or, you know, in the IT, literally, they've taken systems engineering, they're, you know, whatever. Now we have like entry-level people, the new people, like 2 people doing digital entry. And the rest of it is like they're actually going into this whole new field, which is what I'm going to tell you about right now, is that we work with the Ministry of Health. So they were like, well, that's fine and good for your research, but what about the rest of the country? You know, so essentially, I'm not going to tell the details here, but they wanted to apply these technologies, that just the access to the information, and also this e-health and some m-health, some of the mobile applications, to immunization programs, to prenatal care, to pregnancy tracking, to, you know, all this stuff. And so now we've become involved in this whole new area, and the cool thing is that now we're porting everything onto new open source systems. So OpenMRS, OpenClinica, OpenRosa, it's free software, but you need good computer scientists in country. And we came up with this concept called coded in country, which means that over 50% of your computer essentially computer programmers are coding in that country. And amazingly, it's actually now become this coined word. We actually came up with this idea now that we were looking out for some grants, and they're like, but all of your programs to apply this grant has to be 50% coded in country. We're like, yes, you know, so it's really cool. So I don't have time to, you know, this used to be the vaccination registries. I mean, oh my God, like you couldn't find the book, and then you couldn't find who it was, and no one knew where. I mean, they were very good at vaccinating, but you count it by the cajitas, by the little empty ampules and the cajitas, boxes that from the vaccines. You can count them, but you don't know who it went to or what the timing was, you know. And so within like a month, boom, you know, and they facilitate data entry using by decision makers, and then this inventory control system embedded in, you know, it's just like, when did those vaccines come in? You know, so there's like all these different aspects that are really important. One is just to quickly analyze who got vaccinated. The other is what happens to the actual vaccines, and, you know, where the flow of vaccines. And then the other one was to make it an individualized vaccine entry, you know, registry, so that now, you know, the vaccine history, and you know the dosage and the timing, and now all this is now being ported. So the thing is with Access, we did this all in Access because we had 4,000 kids in our study, but there's only 100,000 records you can do in Access. And then they want you to go, you know, to Managua. Okay, Managua's not Cairo, it's not 22 million, but it is, you know, 1.5 to 2 million records. You know, and there's like blank after you end Access. You just have to buy a program. Sao Paulo cost them $60 million to get a program from a company to do this, you know. And no offense, I know, you know, it's like, you know, the point is that for like impoverished nations, what do? Well, you can make it free, but you need good computer programmers. And there's a whole network in Africa where this is super advanced, ironically, by the PEPFAR story, because they have to be distributing all these ARVs. And so there's a lot of really advanced informatics. And so now, but people only want to fund Africa. So we've created the whole thing with Partners in Health. You might have heard of Paul Farmer's organization. So we've been working with them to create the whole program of open source informatics for health in Latin America. And it's really exciting. So we did another healthy pregnancy system called SIMS, which tracks prenatal care and then links it to the kid with the vaccination. And then reporting, like ability to report really quickly. And now it's just boom, you know, it's like we're literally involved in all of these areas. Thankfully, we now have an informatics director and another person, wonderful. So, you know, Mariles is our informatics director in Nicaragua, and then we have a woman who was at Berkeley, and now she's living in Nicaragua doing the SSI's informatics program, working, and so there's electronic health records, surveillance, pharmacy, the LIMS system, mobile phone applications, patient ID and tracking, the supply chain, epidemiology, administration, education, and training. So that we're actually involved in all of these, and there's like all this stuff going on. And we kind of consider like Nicaragua kind of this solutions laboratory where we can actually try out new things, like this new smartphone, you know, how does it work for cold chain delivery, you know, how does it work for pregnancy, how does it work, you know, and so we're doing this with a bunch of different, some of them are like funded by Claro, you know, which is like the which is the telephone company, the cell phone company. Others are like, big international organizations, and it's really interesting, and collaborating, especially with Africa and other countries, and then this kind of skill building. And so, this one thing we've done is move that laboratory system, which was just for dengue. So now it's for the entire nation of Nicaragua. All the samples that come in to the National Reference Center, it could be for like arsenic poisoning, or like urine analysis or any infectious disease, is actually now we've actually done an open source system that's been programmed from scratch to address all these needs, and it's a web-based system. And then there's this integrated eHealth, mHealth pregnancy tracking, and this actually is done. It's like a new project, but it's actually based on cell phones, and so it's actually going out into communities and seeing how these new technologies will actually work and doing pilot tests. And so we've actually moved from kind of this training, knowledge exchange, in the area of this lab information management, in this electronic medical records, and this mobile applications, and then it's expanding to the whole Latin American region. And so we just got funded from the IDRC to do an assessment, again with Partners in Health, and of like the whole Latin American region and where there's areas that this is going to be useful. And then we have a big, and the second meeting of what's called IMECA, which is all of this open source informatics, to actually work through with the people from different countries the projects that they're going to implement. And so, this is just some of the training stuff that's been going on. It's like exploding. Literally, like every other week, there's a completely novel development. And so here, I just wanted to give you an idea. I'm just going to close this part. I tried to give you a sense of like, everything's possible out there, right? What's lacking are the resources. And people are smart. They just need a little bit of knowledge, a little bit of resources, and then they go with it. And you follow, and it's a very exciting trip. But, in the biomedical sciences, I tried to give you this idea how, it started with this technology training with local scientists, but then implementation, new diseases, preventing epidemics, into big research projects. And then a similar thing on a completely different platform, which was this informatics, right? Integration of these information technologies with local health workers and the innovations that they come up with, which really lead to all kinds of areas that we were not even conceiving of in the beginning. And I didn't tell you a whole project, which is this community-based projects that link with social mobilization, which is also, I mentioned now in a random control trial for seeing if we can make this work for dengue. And so I only want to tell you just a few slides. This is not anything conceptual. It's just in case you're going out to Berkeley, that we have a big program out there, and it's called the Berkeley Alliance for Global Health, and I'm director of this Center for Global Public Health. And the thing is that we have had at Berkeley like 35 years, huge number of years in many, many countries, and that what this does is just collate it together. So it's not a new program in global health. It's just a new compilation of global health programs, where the idea is to cohere and synergize the research, an emphasis on translation, on training and education, because we can send students abroad, a big emphasis on policy and outreach, and of course funding. And this is the places that our investigators are already working. So this is just compiling, and a lot of these are like 10 to 30-year projects. They're not just like a one-off bit. So this is where Berkeley faculty are. And then we actually have a lot of Fogarty International grants. And you can see what these are and where they're working. I think actually Berkeley has the highest number of Fogarty grants in any U.S. institution, at least the School of Public Health. Then we have a number of different global health degree programs at the master's level, several of them. We have a track in our DRPH program and in our PhD program. There's like 24 courses or 26 courses in global health, and 34, I couldn't believe this. We're just starting to compile 34 student groups that are working in global health. It's like, whoa, I had no idea. I mean, all of a sudden, like, really? Because everyone's busy. Like, everyone's always overseas doing their work, so we're like never on campus long enough to figure out what's going on. But and we've had these series of yearly symposiums that we have one area, the Center for Infectious and Neglected Diseases, which is more the upstream part, like discovery sciences, structural biology, immunology, engineering, and then we have the little bit more downstream, which is the Center for Global Public Health, which is more about the community and the kind of rolling it out and the interventions and the epidemiology. A big project we have now is on slum health, because there's like 1 billion people living in slums, and it's getting bigger every day, and there's a lot of very interesting health problems which are also linked to land rights, which are also linked to, you know, a lot of important equity issues and et cetera. And so this is a very cross-campus initiative with city planning, engineering, water and sanitation, and public health, and a number of institutional partnerships. And then we send students, we have funding to send about 8 students overseas just through the Center for Global Public Health, and then there's a number of other campuses. So this is where people went over these last years. And we also have clinical training. I know you don't think of necessarily, Berkeley doesn't have a medical school, but we actually have a joint medical program with UCSF, and we have a school of optometry. And so there's a number of clinical projects as well, and a number of other centers. So I just wanted to tell you that, just in case you're thinking about moving in another direction. And I want to acknowledge the amazing people. This is like 1/99,000th of the people who've been involved, and some of whom, like Laura, who's here, and Bill, and Wahala, who've been working with from UNC, for instance, and have been staunch supporters of this effort. Josefina Coloma is at Berkeley. She's also the executive director of SSI, and Aubrey is the director of our influenza program. Marila Benanda is our scientific director. Heather is a director of the informatics program, and this is our informatics director in Nicaragua, and just incredible people in the Ministry of Health, especially in the Department of Virology, and some funding. And I'm going to end there. So, thank you very much. I should just say, you know, if anyone's, I'm terrible at fundraising, but we're apparently like running out of money for a lot of this scientific capacity work. Like in about 6 months, we'll have to like shut that part down. So if you know any generous souls out there who, you know, would like to hear from me, let me know. Josefina, I promised I would tell her, I would say that. So there we go. Anyways, I don't know if you, I really took up my time here, sorry.
That was excellent.
But I don't know if you have any questions. Yeah.
Hasn't the U.S. adopted a lot of these open source technologies? Because I used to work at Cincinnati Children's, and they spent at least $20 million migrating from ISIS to EPIC, which is an e-medical record system, and each component costs, like, there's a separate, like, one for radiology to get, like, images on there, and they don't use fingerprints, we still use barcode scan, but when they come from, like when the local OB hospitals are transferred in, they have a different medical record number, it's not tracked, and that's the best way, would be fingerprints, but what's holding up the U.S. to using e-medical record, a standardized system? Because it seems to be, it would be a lot less cost to use that. I know there's like some concerns about like privacy and things like that, but if other countries can do this, why are we?
Yeah. I sell electronic medical records, and I work for a company called Healthcare Management Systems out of Nashville, Tennessee, and their core business is selling hospital management information systems. I sell to clinics. I sell to ambulatory clinics. But I do know, and I'm not that familiar with the hospital environment because this is a relatively new job for me, although I've been in the industry. But I do know there are a number of open source programs that are becoming more popular, and some out of California. In fact, one of the new employees that joined this company when I did worked for one of those companies, and they did primarily work with the Veterans Administration. They did electronic medical records for all the VA, but I cannot remember the name of the company. So it's a legitimate point and a great question, but I think that is growing very strongly. It does have a lot to do with not so much security anymore, because obviously with HIMSS and some of the policies, I mean, the security is not so much of an issue. There's still a great deal of investment in terms of when it comes down to the end price, because we've talked about this a lot with him, or I have, because it was always a question for me, why wouldn't everybody just go open source? I mean, you can save millions of dollars, but the reality of it is, and again, I'm not that familiar, but by the time you do the assessment of what you need, and by the time you do the implementation and pay the maintenance of the software, because the maintenance is not free, realistically, in the end, and this may certainly probably not true in the countries you're working with, but I know this in the United States, essentially it's about the same price. It's not that much different. And then there are some, that have the old thinking that, well, I'm going to mitigate my risk by going with an IBM or going with an Oracle because we know they're going to be around. And, when you look at a big metropolitan hospital or a big institution, and their investments in information technology and the resources they've trained, I mean, there are a lot of things that come into that decision about, You know, do we go with an open source, not knowing really where it's going to go, or do we go with someone and pay a little bit more money? And you know, but it's I think that your point is very valid, and I think open sources will become much more part of information technology. I mean, I think that's the way the industry's going, but I think we're not that close yet for it to really be the standard.
I think, like, well, it also, like, for instance, with, I used to get this question all the time, like, PCR, we can do it for 7 cents, and yet it's like $35 if you buy it here, kind of thing. And part is also, like, the patents and things like that. And part of it's a quality control issue, I think. Like you're saying, you know, you've got your whole hospital, and you want to, like, someone to back you up on that. And, you know, because, like, malpractice and this and that, I mean, all this stuff is, it's a very legalized society here, you know, and so people are always trying to mitigate their risks. Whereas in other countries, it's like, there's no option, right? And so, like, why not, you know? And it's a great way to build, you know, local human capacity. And, you know, there are a lot of smart people, you know, and probably the salaries are probably less than they are here, you know, so you can get, I mean, there's, you know, computer hackers and wonderful programmers are everywhere, right? And so they're just, it's a great job. And so I think that what's going to happen, like it's happened with a couple of other of these kind of applications, mobile applications, and et cetera, is that in the you'll get like a couple of years, maybe 10 years of development in developing countries that will knock out a lot of the bugs and the issues and everything, and get the open source up to a quality that potentially then might be able to migrate back in here. Although, you know, we all know, right, there's profit motives and there's this, and, you know, things get settled and et cetera. So I think that it's always more complicated in a system that's used to that kind of a model, and that's already kind of all gridded up, you know, whereas it's much more open in other countries where there kind of isn't a choice, and, you know, and where you can have people who are on top of the quality control because they don't have another job, you know, and so I think that that's part of the story.
I think what's so exciting is that just with those resources that didn't have anything, how quickly they grew what they have, and they have so much more now. And they weren't hindered by the bureaucracies and all the policies and the guidelines. And those are good too. I mean, there's a point where you have to have that. But I think it's amazing.
I mean, not that this is easy. Like, this has been the trickiest area. Actually, it's interesting because in the biomedical field, it was just like, you know, like we could just, sure, do PCR, and then we could apply it to another disease, and we could do this, and we could, you know, the whole Ministry of Health was like, yeah, let's work. But there's a lot of companies that are coming through Nicaragua and this and that, so there's like a lot of confusion about, you know, like, and then there's the CILAI, there's like the Central Ministry of Health, and then there's the one that runs the Managua system, and then there's the, you know, and then all these people are coming and so there's different companies that are coming to Nicaragua and talking to this and talking to this and talking to this, so that each group is like makes some link with a different company, you know, and each hospital has some different system because someone's friend said blah blah, you know, and so then it's like all confused, you know, and so then they're like, and then of course, as in many countries, they're like constantly rolling heads. So as soon as like you establish, okay, this is how we're going to do what, you know, that person's out, and you're like start again with the next one, and you know, as soon as you get the like confianza up, then, you know, so it's challenging. And so we just said, you know what, oh my God, we're just going to do this. Like, we're just going to do it because we work in a health center, we work in a hospital, we work in the labs, we're just going to do it. I'm always a woman of action, right? Just, we're going to do it, and then if you like this, then we can work with you. And now they're coming around, you know, now the ministry is like, hey, you know, can you come here, can you help us with this, can you do this? You know, but we just said we're going to do our pilots and let the actions speak louder than words.